All right, well, welcome everybody. It looks like it's just noon here in Seattle, so we'll go ahead and get started. We'll give some people some time to log in. We'll just introduce a little bit about the webinar series and the and our MHTTC as we're getting started. I want to welcome everyone to today's webinar, Pharmacologic Considerations for ACT Team Prescribers, focus on clozapine and long-acting injectable antipsychotic medications. I'm Dr. Lydia Chwastiak. I'm the co-director of the Northwest MHTTC, and we're delighted to have a great group here as part for this webinar. This is the second webinar of a 4-webinar series that focuses on topics related to the role of ACT psychiatric care prescribers. And there's some information on this slide. The meeting is being recorded. The recording and the slides will be available to you on our MHTTC website in 1 or 2 weeks. And just in advance, we'd love to have you complete an evaluation at the end of the session because the feedback is very important for us to keep free training coming. So I'll tell you a little bit about our network. And for those of you who are just joining in, please chat in your name and your role on your ACT team and your location. But just as an introduction to our network, the MHTTC network is a nationwide network that's supported by SAMHSA. And the network includes 10 regional centers and a network coordinating office that's located at Stanford University. Our Northwest MHTTC that's just been circled covers HHS Region 10, which is Alaska, Idaho, Oregon, and Washington. MHTTC network supports resource development, dissemination, training and technical assistance, and workforce development for the mental health field. A bit more about our Northwest MHTTC. Our goals at the Northwest MHTTC are to accelerate the adoption and implementation of mental health-related evidence-based practices, to heighten awareness, knowledge, and skills of the mental health workforce, to foster alliances and address the training needs among diverse partners, and to ensure the availability and delivery of free, publicly available training and TA. I co-lead the center along with my colleague, Christina Clayton. The focus, each of the regional centers in the national network has an area of focus, and our area of focus is evidence-based practices for serious mental illnesses. But and in particular, assertive community treatment, cognitive behavioral therapy for psychosis, coordinated specialty care. But we do provide training across a broad range of topics, including integrated care, co-occurring substance use disorders, and suicide prevention. You can see the list on the slide. We do free training and technical assistance, free self-paced online courses, live events like the webinar today that will be recorded and posted for people to view later, and then virtual learning communities. So you can check out our website to learn more about our goals and training opportunities and resources. So as people are joining, it's nice to see a great group today. Please chat in your name and your role and your location. Just wanted, before we move to today's speaker, wanted to provide some housekeeping tips. There are both a chat and a Q&A function on your Zoom screen. We'll use the chat for technical issues. So Peyton will be monitoring the chat. If you're having any trouble, he can help troubleshoot if you put that in the chat. If you have general observations or general comments, feel free to chat those in. But if you have questions for today's presenter, please put those in the Q&A. We'll be moderating the Q&A and save time at the end of the session, probably 20 to 30 minutes for a chance to go through questions and answers. As I mentioned a few minutes ago, we're funded by SAMHSA. We are required to provide just a very brief amount of data, evaluation data, in order to continue providing free training and TA. So we would ask at the end that you can take a few minutes to complete the evaluation. So there'll be a QR code. Peyton will also put the link to the evaluation in the chat. So we'll take some time at the end of the session to do that. You can find out more about us and register for additional training opportunities, resources at our website, or through social media. So please feel free to connect with us through those means. So I will just kind of introduce our team here that's presenting this webinar series, and then we'll introduce today's speaker, Dr. Cotes. So just a quick introduction for me. As I said, I'm Lydia Chwastiak. I'm a psychiatrist and professor at the University of Washington. And my research over the past 20 years has aimed to improve medical care and outcomes among people with serious mental illnesses across a range of low resource settings. And I co-direct the Northwest MHTTC. And I will turn introductions over to my colleague, Maria Monroe-DeVita from the University of Washington.
Hi, everyone. Welcome. It's so great to see so many familiar faces and names on here today. As Lydia said, I'm Maria. I'm a clinical psychologist by training, and I co-direct the Spirit Lab at University of Washington, which is a center that provides, among many things, implementation support to our 22 PAC teams in Washington State, some of whom I see are on here today. And then I also train and consult to ACT teams across the US and co-developed the tool for measurement of ACT or Team ACT fidelity measure. And that's a good segue over to Lorna Moser.
So I'm Lorna Moser, and I'm the director of the Institute for Best Practices here at UNC within our Center for Excellence in Community Mental Health. And pretty much of what Maria had just said is same for me, clinical psychologist and co-author of the Team ACT, and do a lot of work with ACT providers in our state here in North Carolina and in Virginia and elsewhere. So great to be here.
You want to go next, Steve?
Yeah, hi, Steve Harker. I'm a psychiatrist in St. Paul, Minnesota. Right now, I'm doing ACT on a forensic ACT team, and I'm medical director for Radius Health there. I was first on an ACT team in, I guess, 1997 when I was in my psychiatric residency in Madison in Dane County. And it started here in Minnesota in 2005. And so since then, I've been involved with trained to do the TMACs and done a lot of fidelity reviews. And there's a residency program in town that I coordinate placement of their residents on ACT teams and educating them. And so glad to be here today.
And Anne.
I'm Ann Hackman. I am an ACT psychiatrist at the University of Maryland in urban Baltimore. Steve, I actually also came to this as a resident a few years before you did, back in 1993, and I have worked with the same team consistently for a little more than 30 years now. And pleasure to be here today. Thank you so much.
And those are all of our co-facilitators today. We'll introduce Dr. Cotes here in a minute. But the next thing we want to do is just learn who is on the call today. We appreciate those of you who put where you're from and your names and lots of really good specifics in the chat. And if you haven't done that already, I think it's a nice way to get to know who's on the call and make some connections even within the same state if you aren't connected yet. But in the meantime, you're going to see a poll pop up on your screen where we want to know if you're a psychiatrist, nurse practitioner, physician assistant, psychiatry resident, or represent another role on an ACT team. So we'll give you just a couple of minutes here, not minutes, seconds, to put your response in there. And then I'll share the response here in just a minute. Looks like we got a pretty good final. And it looks like we've got, is it showing? So about mostly 38% nurse practitioners, 20% psychiatrists, 39%, so almost 40% represent another role on the ACT team. And then we have 3% physician assistants and no psychiatry residents. So thank you. That's helpful for us to know. Also, just wanted to be really clear too that today's presentation is going to assume a level of technical expertise and education related to prescribing. So if people have other questions that you want to put in the chat, we'll do our best to still at least respond to some of those. But the focus is really on kind of ensuring that we're answering the questions of our psychiatric care providers that are on today's calls, and then we can again point to other resources for the rest of our group. So the next slide, please. I just wanted to make sure we plugged this in our last call, but just to put to everybody's attention that our National ACT calls, which Lorna and I co-facilitate. Our last one was June 3rd. And we had the Oregon Center of Excellence for Assertive Community Treatment, or OCACT, introduce a new ACT nurse curriculum. And so if you didn't get a chance to see that, I'll put a link in the chat to the recording for that and the slides for that. A really awesome opportunity, I think, to get our nurses on our ACT teams up to speed on kind of providing more consistent and coordinated care within the team, and many of those role functions, again, aligning with the Team ACT fidelity scale. And then, as Lydia said, next slide, we've got 2 more calls like this in the series. So July 18th, we've got our focus will be on addressing cardiovascular health, and Dr. Martha Ward will be presenting then, again, the same time, 12 to 1:30 Pacific. And then our last call will be August 15th, where Dr. Jeremy Welliff and Dr. Timenta Terrence will be focusing on updating substance use disorder care in the age of fentanyl and stimulants. So they'll talk more about their harm reduction and treatment approaches there. Let's see. So next slide, I think we're just shifting into, yeah, and then we'll be doing an evaluation after this, but I think this is a good time then for us to switch over to Dr. Cotes, and I'll let you introduce yourself more, Rob, but I just wanted to share with everyone, some of you may be familiar with Dr. Cotes from his work with the SMI Advisor. He's also an associate professor at Emory University School of Medicine in the Department of Psychiatry and Behavioral Sciences, and is a physician expert for SMI Advisor, which is also funded by SAMHSA and administered by the American Psychiatric Association. I'm sure he'll be pointing out lots of resources that they provide in these 2 particular topical areas, which have their own centers of excellence within SMI Advisor. So we can also put a link to those resources as well in the chat for those of you who are also coming to this and aren't a psychiatric care provider already, but want to have more familiar access to that information, as well as for those of you that are psychiatric care providers. So I'm going to turn it over to you, Dr. Cotes.
All right. Thank you, Dr. Moreau-DeVita. It's just really great to be here. We're going to talk about Clozapine and LAIs with, I think, a slight, maybe a little bit more about Clozapine than about LAIs. And let's see, disclosures. I am not an ACT psychiatrist, but I actually used to be an ACT psychiatrist, where I ran sort of part of a Clozapine ACT team. We had about 30 individuals on Clozapine, and everybody was all sort of on this one of our 3 ACT teams. And I got an opportunity to do some ACT work. Right now, I also run a coordinated specialty care program for people with early psychosis and a Clozapine clinic that we established in 2012. And we also, we'll talk a little bit about SMI Advisor and how SMI Advisor can kind of help you with some resources in Clozapine and LAI type topics. The other thing I would say is, the MHTTCs are really all about implementing evidence-based practices, in particular the Northwest MHTTC. And, if you look at the APA schizophrenia guidelines that were published in 2020, there are 11 statements that are about psychopharmacology. 4 of those 11 statements are either about Clozapine or about LAIs. So this really is, I think, a cornerstone of pharmacologic management. But then, of course, backing up that pharmacologic management is only, I think, part of the way to help really optimize outcomes. All right. Here is our SMI Advisor slide. We are funded by SAMHSA, and we are administered by the American Psychiatric Association. I'm going to try to bring in my experience over the years with SMI Advisor, doing a lot of consults. So people will write in a written consult to us, and I do a lot of the pharmacology consults around clozapine and around LAIs. And I've learned an incredible amount by the questions that people have asked. And I'll try to bring in some of the things that people ask most about regarding clozapine and LAIs.
Rob, I
Yes.
wonder if you are able to turn up your volume just a tad. We just had a comment that it was a little harder to hear you.
Is that better? Can you all hear me?
It's still a little low. I don't know if people can also turn up their own volume on there to hear you. But I just thought I would let you know in case it was being hidden by your code or something.
Could be. It could be my new glasses. That might be the issue. Is that any better?
Yeah, that is better. Yes, your
Okay.
new glasses may be doing it too.
All right, I'm going to ditch the glasses.
I'm kidding.
And let's see if that helps. So, all right. Yeah, unfortunately, Dr. Donna Rowland is not going to be able to join us today, but she's sort of one of my counterparts at SMI Advisor, and she's a psychiatric nurse practitioner, and she does a lot of work with me in the Clozapine and LAI centers of excellence. So she gave everyone her regrets and really wish she could be here, but wasn't able to make it today. Here are some disclosures that I have, and I'm also an unpaid consultant to HLS Therapeutics. Our learning objectives. I think I'm going to really try to get to a couple things, but we're going to talk a little bit about how important it is to initiate clozapine early on and how actually long-acting injectables can help you get there more quickly. Then we're going to talk about using therapeutic drug monitoring. Then we're going to talk about another very common question for people who are on clozapine. What sort of pharmacologic and non-pharmacologic strategies do you use to help them reduce symptoms in different domains? Here's an outline. We're going to start with LAIs, then clozapine, and then talk about different things in clozapine. I don't have a section in here where we're going to discuss clozapine side effects particularly and managing clozapine side effects. And we can talk about that in the Q&A. Managing, antipsychotic induced weight gain. We could talk about GLP-1 receptor agonists and how to use those and those types of things. But I actually don't have anything in this part of the talk about those topics. So we can get to that in the Q&A. All right, first, so we're going to talk about long-acting injectables. And I think that there's been a bit of a paradigm shift of long-acting injectables from, more of a, instead of someone being inconsistent with medication and then, maybe having some relapses, LAIs are used kind of as a punitive thing. I think now there's more thought about using LAIs a little bit earlier on and just presenting them as another way that we can offer a different type of formulation of medication to our folks. So I want to show you what the APA schizophrenia guidelines say about long-acting injectables, which you can see here. The interesting thing about this is that many insurance companies, they don't really, the part about if individuals prefer such treatment is not part of the criteria for approving LAIs. It's about a history of poor or uncertain adherence. And I hope that that eventually will change because some people just would prefer to be on an LAI. The thing with an oral antipsychotic medication is, they're going to be, it's going to be peaks and troughs that occur much more frequently than with a long-acting injectable. There is a concept called the peak to trough ratio for LAIs too. So, after an LAI over the course of the month or 2 weeks or however long the cycle is, more of that is going to be sort of released from the body. It doesn't appear like there's clear evidence to me that the tolerability profile of LAIs really differs much from their oral counterpart. So although I think the plasma levels are a little less fluctuating with LAIs, I don't necessarily think that means necessarily a better tolerability profile. And also, it doesn't really make much of a difference from an efficacy standpoint either. And here's just a little bit about LAI utilization. It's interesting to know that, across states, LAI utilization varies. And there has been some efforts, within clinics to increase LAI use. Different sort of methodologies have been used for that. I tried to put a couple relevant to the Northwest MHTTC over here, Washington, Oregon, and Alaska. I couldn't find Idaho, so I apologize about that in the graph. It might have been an oversight on their end, or maybe it's there and I just couldn't find it. But there's a wide variation, and approximately, I would say, 13% of people with schizophrenia are on a LAI in the US. So there are, I think, interesting questions about the efficacy of LAIs in comparison to the oral counterparts. And, as you sort of look back at the evidence and you look at sort of registry studies and observational studies, people with LAIs tend to do better than those who are on oral antipsychotics from an adherence standpoint, from a rehospitalization standpoint. In RCTs, it's a little bit different because everybody has to sign up and agree to participate in an LAI arm or an oral arm. And some people argue that that's maybe not exactly a real world naturalistic population in which this is going to be studied. So I think that the registry studies and some of the retrospective cohort studies are pretty compelling, that basically suggest that LAIs may have superior efficacy, in terms of reducing psychiatric rehospitalization as a result of decreased non-adherence. The other question that often comes up about, is there one LAI that's more effective than another? And the answer is probably not really. There was a recent meta-analysis looking at comparative efficacy of LAIs to LAIs, and many of the commonly used LAIs sifted out on that, including paliperidone, aripiprazole, and olanzapine. I thought that this study called the PRELAPSE study was a really important study, looking at long-acting aripiprazole versus treatment as usual for early psychosis patients. And they basically found that, in a cluster randomized design, the number needed to treat to prevent one hospitalization was 7. And I think evidence like this suggests that early, discussing LAIs early on with people is important, and is also just another preference that people can have. I wanted to just share with everyone some of the new LAI options since 2021. So the LAI landscape is becoming increasingly busy, and sometimes it can be hard to keep track of it. Different systems, I think, are using and getting these LAIs approved in different ways. Sometimes in our system, maybe at the state hospital, someone will start on one LAI antipsychotic that might not be available in the outpatient setting, and there need to be some transition made. This is a list of some of the newer LAI options since 2021. We have a new aripiprazole product, which is administered every 2 months. We have Invega Hafera, which is a 6-month version of paliperidone. Braikindo, Uzedy, another interesting risperidone extended release product, in which actually oral overlap is not required. It's given every 1 to 2 months. You can actually start the Q-month dose right away. And then in March, there's a brand new risperidone product called risperidone ISM, or ROVI. And ISM stands for in situ microimplants, which I would be hesitant to tell my folks about. But anyway, ROVI is new. I haven't seen anybody use ROVI yet. It's kind of like Braikindo. It doesn't require oral supplementation, and it's given monthly. A lot of what people ask about in the consult system is the management of breakthrough symptoms. Sometimes they're called breakthrough symptoms on antipsychotic maintenance medication, or BAM. And this actually is a fairly common situation where someone might have some, partial increase in positive symptoms, maybe as the LAI is wearing off. And this is a flow sheet that I can make sure you have access to that helps you kind of think through what to do if somebody has breakthrough positive symptoms. The first is to think about like why, like is there a different stressor going on? Maybe this isn't a pharmacologic problem that needs to be addressed. Another one is, are there maybe substances are involved, and like maybe that's something to talk about. Are there other comorbidities? But the first thing to think about is if the symptoms persist, you can use a low dose of the oral antipsychotic, the same oral antipsychotic. Like if it's Invega Sustenna, using something like Invega or risperidone in the short term, reevaluating and seeing if you could stop it once the person gets better. So I thought that this is a kind of a helpful way to frame LAI sort of breakthrough symptoms. What happens for some people is that if it's a monthly injection, the monthly injection isn't enough, like at week 3. So some people might shorten the LAI injection interval to Q3 weeks instead of Q4 weeks. This is off-label. Some insurance companies don't have a hard time covering that. But you can see that that's sort of documented here as a potential option if that's needed. But again, I think the main point is to try using the same oral antipsychotic if you can. And then at some point, you're going to need to determine if someone actually is not responding to the long-acting injectable, which is a slightly different conversation, which we'll get to. So, I think there can be a real benefit to considering therapeutic drug monitoring for long-acting injectable antipsychotic medications. And a key thing with the LAIs and TDM is the timing of the level. So, for oral antipsychotics, as a convention, we get the level 12 hours after the PM dose. We tell people to hold the AM dose. For LAIs, we try to get them, maybe a day or 2 before the next injection is due. So if somebody's on a monthly injection, you can get the level before they get the next injection, and that's the trough. And that's sort of what's reflected in the literature. So I've put some, norms in here around the therapeutic threshold and the point of futility, and then the lab alert levels. And sometimes, if I'm considering a client for Clozapine and they're on an LAI, I might get a level of the LAI to kind of understand, is this a pharmacokinetic issue, or is this just a lack of response? The other thing that comes up is combining LAIs sometimes. And in ACT teams, we will see people who are on multiple antipsychotics and sometimes multiple LAIs. And there's really limited evidence on using multiple LAIs together. There was a recent systematic review that was published this year that summarizes what's known so far. And, it was an unexpected finding where they basically just said everybody did well and there were no unexpected events, no unexpected adverse events. And I think this just speaks to the lack of data that we have. But aripiprazole and paliperidone are the most common combinations, 32 times in the literature. You may encounter some challenges with insurance coverage. The same sort of considerations apply with antipsychotic polypharmacy. Like if somebody's on 2 antipsychotics and they have persistent positive symptoms, I think about Clozapine kind of as the first thing. But there are some people, for whatever reason, who, Clozapine's not feasible. They might be doing well on 2 antipsychotic medications. The other thing with the 2 antipsychotics is sometimes, like if you have 2 monthly LAIs, you can stagger them every 2 weeks instead of giving somebody the same, 2 LAIs on one day. I would probably stagger it every 2 weeks if you have to do that. Something else that we see a lot in the LAI Center of Excellence is switching LAIs. So like you want to maybe go from, you know, Risperdal Consta to Abilify Maintena, for example. And this is a nice paper that kind of really goes over in pretty practical detail how to switch from one antipsychotic to another LAI antipsychotic that you can check out. We get a lot of consult questions on how to do these types of switches. When do you initiate the next LAI? Do you use an oral bridge? I think one of the key principles, though, is you want to establish oral tolerability with whatever the second agent you use before you administer the LAI. And I think there's different ideas around how long to do that oral tolerability period, depending on the medication. And, you know, I think there's not a lot of guidance often from the US package insert around how long that oral tolerability period needs to be. So I think that, you know, LAIs are a really important tool. We, in the early psychosis program that I'm a part of the young folks that are taking medication, I think about 40% are on a long-acting injectable currently. But maybe we can stop and see if any of the other co-facilitators have any thoughts or reflections on kind of what we talked about on LAI so far before we go to the clozapine.
Other questions too? Go ahead, Anne, please.
I was just going to say, I think it's great that there's now evidence to support things that I've been doing for a long time.
Yeah. And yeah, I do have a few people on 2 injections. How you get there varies quite a bit, but one person in particular definitely benefited going from 1 to 2. And I staggered them, like the question.
Okay, sounds good. Are there questions we should get to in the chat, or shall we just go forward to clozapine? I'm always happy to go forward to clozapine. It's like my favorite.
Yeah.
Yeah.
I think we got the question in the chat you answered in one of your slides, so I think we're good. And I think just maybe to acknowledge or I appreciated your comment about the culture around this shifting around like ensuring that this is more of a person-centered approach to using LAIs, and that it's not just if you don't take your medications, you'll have to go on an injection as like a punitive thing. And also just recognizing within ACT, we always have to strike a balance with that because of the assertive nature of the work that we do. And so appreciate your acknowledging that, Rob. Thank you.
And if I can just interject, I was stunned in doing first episode work by how many young people said, please give me the long-acting shot. Then my mother will get off my back. If I get a shot that I take every 3 months, I can go off to college with no medications and no one will know anything that I don't choose to tell them.
That's a great point. I think I've seen that a lot too, is you know, in a person-centered way, the LAI can really help to avoid some of the power struggles that people could get into about taking a medication every day. And I really want to emphasize, and I have not emphasized this enough, sort of how, you know, medication can be one of many tools to help people accomplish their goals and the kind of things that they want to do. And connecting the LAI to someone's recovery goals is often more powerful than, you know, just sort of taking a symptom-focused approach where the LAI can, you know, help to reduce issues that people might not necessarily be on the same page with you about. Okay. Clozapine. So yeah, it's an interesting time for clozapine right now in 2024. There's going to be an FDA sort of a joint meeting of the FDA this fall that's going to review some of the REMS requirements to see if there can be any modifications made to the monitoring schedule and to REMS in general. And I think various stakeholders, including the APA and NAMI and APNA, National Council, AACP, have been interested in partnering together to make clozapine more accessible and help to reduce some of the barriers. We talked about the APA schizophrenia guidelines in 2020, and this is just kind of what it says about clozapine. 2 of these are FDA on-label indications. Number 1, clozapine after minimal to no response to 2 antipsychotics. And then number 2, people are treated with clozapine if the risk of suicide attempts or suicide remains substantial despite other treatments. And this point number 2, I think, is really where people don't think much about clozapine. On ACT teams, there's a lot of different kinds of people experiencing different kinds of things on ACT teams. Sometimes it's suicidality, sometimes it's psychosis, sometimes it's mania. And clozapine can actually be a useful tool, not just for treatment-resistant schizophrenia. So treatment-resistant schizophrenia, poorly named, but that's kind of what we'll call it for now, since that's often what's in the literature. And then the other part is sort of with a slightly lower level of evidence that people with schizophrenia can be treated with clozapine if the risk for aggressive behavior remains substantial despite other treatments. So, if you're working on an ACT team and you see people who have schizophrenia, you could probably estimate that a quarter of them will have, this persistent symptom of psychosis despite 2 antipsychotic trials, despite taking the medication itself. So if you look at your ACT roster and you have like 100 patients and you look at the diagnosis, you can kind of estimate like how many people you think might benefit from clozapine, and sometimes there's more and sometimes there's less. But anyway, I think that this sort of I used to run this clinic called the TRS clinic, and I had this young woman come in and she said, what is the TRS clinic? And she was doing really well on clozapine, and I had to tell her it stood for treatment-resistant schizophrenia, and it was a huge embarrassment for me. And we renamed the clinic because people with this so-called TRS thing can really do quite well, and they can recover. And it's not fair to probably call that TRS. It's probably fairer to call it, clozapine responsive schizophrenia, something like that. But anyway, it's a really negative, I think it has pretty negative connotations. What we do know, though, is that, for people who fail 2 antipsychotic medications, clozapine is really the only logical choice at this point. Other medicines just really aren't expected to work. High dose medication, combining medication, it's just very unlikely to be effective. So really, after, maybe 2 antipsychotic failures, but not more than that, it's time to start thinking about clozapine. If you think about like the proposed number of people with TRS in the US, which is maybe 23% of people with schizophrenia, less than 5% are actually on clozapine. So there's this big gap, I think, in the utilization of clozapine, 18%. And the only way that we make a change with this is by starting new people on clozapine. It's not enough just to sort of, work with somebody that transferring them to you. That's good, but I think actually starting new people on clozapine is the only way that we're going to figure this out. What we've come to understand more recently is that starting clozapine early on really makes a big difference in the outcomes, which is why I argue that coordinated specialty care teams, early psychosis teams, is where we talk about clozapine. And some people might say, well, why? That's, more of a last resort. And it's a myth that clozapine is a last resort. Clozapine needs to be used early on because people can do extremely well with clozapine. And this study basically showed that if you, have a delay until the diagnosis of TRS less than 2.8 years, the response was 81%. A delay greater than 2.8 years, the response was 30%. Now, that doesn't mean that if there's a delay of 5 years or 10 years, which is what I often see, that it's hopeless. People can still do quite well, but I think it means that perhaps there were some missed opportunities earlier on. So, in our early psychosis program, we try to, encourage long-acting injectables early on if people are interested in them. And then after that, really start talking about clozapine. Everybody on the team talks about clozapine. So it's not just the prescribers, it's the peer specialists, it's the, it's maybe other people in the program that are taking clozapine are often the best ambassadors for this. But really, I think the education is sort of on the team at large, which is why I'm glad that many of you here are prescribers and non-prescribers. Here are some tips to try to identify TRS folks. And there's a concept called pseudo-resistance where, actually it's not treatment resistance. Maybe it's non-adherence. Maybe it's a pharmacokinetic issue. Somebody's an ultra-rapid metabolizer of an antipsychotic, and they're just not getting enough. So I think that if you look at persistent positive symptoms on LAIs, that's a key place to intervene, really. And then sometimes, if somebody has a young age of onset, childhood schizophrenia, very rare, but that's a common predictor of TRS. About 60%, maybe 60% of people or so develop TRS kind of right out of the gates early on. And then there's another 40% that develop it more over time, sort of after experience with various antipsychotic medications and maybe some level of dopamine supersensitivity. But it's sort of an ongoing thing, and there's periods of non-adherence and then starting meds again, and then non-adherence, starting meds. There's a subset of people who kind of develop TRS after that. Okay, clozapine and suicide. I know I mentioned earlier how this is a major public health problem. People with schizophrenia have a lifetime risk of suicide around 5%. And the risk is really early on where it's the strongest. We know this through data from the INTERCEPT study. We know this from data from registry studies that clozapine tends to reduce suicidal behavior. It's hard to do RCTs that show that clozapine reduces suicidal behavior. So some colleagues and I did a study looking at the protective effect of clozapine on suicide, looking at people who had actually died in the Maryland Office of the Chief Medical Examiner. And it's interesting, in the Maryland Office of the Chief Medical Examiner, they get therapeutic drug monitoring, or they get levels on everybody. And you can actually see if somebody has clozapine or olanzapine in the system. So it turned out that of the people that had died, they were much more likely to die by suicide when olanzapine was detected in the system in comparison to clozapine. So again, sort of another way of looking at this sort of unique property that clozapine may have. I just recently came across this study that showed that in a sort of a Kaiser data set, of people that had a diagnosis of a psychotic disorder with suicidal ideation, only 1.1% received a prescription for clozapine over the 12 months. So really underutilization in this area. And this is true too, in the clozapine program that I run, where we've had, I think at one point we had 500 referrals, and then, about 4% of them were for the reduction of suicidal behavior. So even people who are thinking about clozapine don't think about it for this. And also, the third indication that we've been talking about is clozapine and aggressive behavior. And, there's been some nice work that's been done by Krakowski and colleagues looking at different medications, clozapine, olanzapine, and haloperidol, showing clozapine superiority. But also there's another NIMH-funded study right now going on called the Revisit C study, which may give us which is really focusing on clozapine and the risk of violence. Okay, so maybe before we go forward, we can hear about any questions, and then we could talk about some ideas about starting clozapine, how to do it.
Just a couple thoughts on clozapine and ACT, where you're trying to help people find jobs and integrate into society. I've really noticed that it improves cognitive deficits of schizophrenia more so than the other antipsychotics, and improves ability to maintain job. Speech fluency can go up where suddenly there's more reciprocal conversation, better attention to how you look when you're in the mirror because your cognitive deficits are better. So you can really see a huge difference in somebody's ability to integrate into society in general when they're on clozapine. I guess the other thing too, huge impact on substance abuse. There's some studies where substance abuse and schizophrenia, clozapine has a pretty profound effect there as well. So I love clozapine. And it's just such a great med to use, especially when you got a team doing rehab.
I would concur. I think it fits in so well with the ACT model. I have had personal experience with individuals who had horrific substance use disorders and all of the treatment refractory psychosis. And with clozapine, when it works, I've seen people stop their substance use almost magically. And of course, it is not tolerable for everybody, but it's so great when it really works well.
So what do you guys do? Are you guys seeing a lot of sedation with the Clozaril?
So yeah, I mean, I think sedation is really one of the main problems that clozapine has, especially, when people are working and in school. And, it's our clozapine clinics, I think, are busier in the afternoon than in the mornings because of this. I mean, it's a major issue. There's a number of different ways you can kind of think through it. First is prescribe clozapine at just bedtime instead of BID or TID dosing. After that, you want to kind of minimize other sedating medications. Try to take it earlier in the night, things like that. Then there's a whole wide world of, pharmacologic effects to help counteract the sedative sort of sedation properties of clozapine, none of which are great. But I think sometimes people will consider bupropion, modafinil, armodafinil, and low-dose methylphenidate in some rare cases. But really, we try to do everything we can to avoid any additional pharmacology to manage the sedation. But it's a major problem, and I think a big key is removing the other sedating medications along with it.
I've found that with very, very gradual titration, in one case, a whopping 6.25 milligrams a week, that when you do this really slowly over time, sedation seems to be less of an issue.
Yep. Ultra slow. That's what I do. 12 and a half every other day sometimes.
Totally agreed. And we'll talk a little bit about some ideas around titration. Maria.
Yeah, we just had a couple of questions that just came up that I thought we would go ahead and propose now, since you were asking some of these. One is so a question about pre-clozapine initiation guidelines. So this person is suggesting at least they were trained to always get an ECG and a CBC within 7 days of starting clozapine, and just wanted to make sure, kind of, is that standard protocol, or what is the standard protocol now?
Yeah, we're going to talk a little bit about the monitoring in just a moment. And I think that you do probably need you do need an ANC before you initiate clozapine per the REMS guidance. But an ECG though can sometimes be helpful because a large number of people will develop sinus tachycardia. It helps to have an EKG before that, but it's not for us. An ECG is not. That doesn't stop us from initiating clozapine. In many situations, it's difficult to get. Like in our clinic, they have to go to the main hospital in order to get the ECG. There's a lot of ways that can go wrong. So that doesn't necessarily prevent us from initiating clozapine.
And then the other question, which I know came up in we did some ACT psychiatric care provider calls in the last year of our MHTTC. And one of the questions had come up around some of the agencies already using point of care testing, the finger stick for ANC monitoring, and any updates on that. And a related question is how to manage the lab draws, especially when people, it's difficult to get them to the lab, or needle anxiety, which I think this would address. But do agencies need specific certification or to be able to do it, that kind of thing?
Yeah, yeah. So let me respond to that one during this next section where we talk a little bit about monitoring and point of care testing, because I think that's a key issue. And I think the number one barrier for clozapine is its ongoing hematologic monitoring from both organizational, prescriber, and sort of patient standpoint. So I think like the ACT team is really uniquely suited to use clozapine for the reasons we've been talking about. I mean, the team approach and maybe everybody talking about clozapine, thinking about it can really be helpful. You get multiple observations. There's a 24/7 way you can access the team if there's issues. The ACT team can really help facilitate inpatient to outpatient transfers. The ACT team can really sort of manage outpatient initiations, help with education, like don't prescribe ciprofloxacin to somebody who's on clozapine. And then also, I thought of this earlier today when I got a new iPhone, that there's an Apple Medical ID that you can look at that, basically allows somebody to see, what medication you're on without having to actually go into your phone. And clozapine, people who take clozapine, often have many other medical comorbidities, sometimes wind up in the emergency room. Sometimes the emergency room doesn't know that they're on clozapine in some settings. And like a medical bracelet or using technology can really be helpful, and ACT teams can help people set that up, in addition to, sort of like a Ulysses clause, or kind of in different states they have these. Sorry, I'm blanking on the name of the clauses. But ACT teams can help to set that up for people. Which hospital to go to, how to get treated, how people want to get treated, et cetera. Okay, so I think what happens a lot of times is on ACT teams, there's a variety of everybody's doing the best they can, and sometimes you see people on an ACT team who are on like multiple medications, and you got to figure out what to do. And what I like to often think about is, if I'm starting somebody on clozapine, trying to remove the anticholinergics, sodium valproate, benzodiazepines. If there's some data that suggests that using Depakote and clozapine together can increase the risk of myocarditis. If somebody doesn't need to be on Depakote, they might not need to you can consider stopping other constipating medications like opioids. And then, you may be encountering situations where somebody's on 3 antipsychotics and you want to start them on clozapine. Which do you go with first? And in that case, I usually think about the more sort of antihistaminic, anticholinergic one. And then I usually, depends on the situation, but won't start the cross type, won't start reducing the other antipsychotic until someone gets down to, has a little bit of clozapine on board, actually. Usually about 100 milligrams or sometimes a level. And then there's sometimes where, like in the hospital, you may see someone who is on no medication. They're kind of a clozapine person, and sometimes they need to be on another antipsychotic as you're titrating the clozapine. The slow titration is essential. So sometimes another antipsychotic helps. This is a tool from Australia it's sort of an antipsychotic switching tool that you can check out. But it doesn't allow you to input 3 antipsychotics and then say, how do you get this person onto clozapine? That's what the SMI Advisor consult system has been helpful for in the past. All right, now back to the monitoring question. So this is a sort of kind of what we like to do, and this is based on a paper that Christophe Correll wrote, sort of the baseline labs. We like to do a myocarditis screening protocol for the first 8 weeks in the outpatient setting. The ECG is kind of optional, it's not possible with everybody. So baseline ANC, CRP, troponin, lipids, hemoglobin A1C and ECG if possible. I like to get a level usually around 100 milligrams. And then we do neutropenia screening as per the REMS guidelines. Then ACT teams can really help facilitate vital sign monitoring, early on, a couple times a week if you can. I also like to do interstitial nephritis screening weekly until week 8, serum creatinine, and then the myocarditis screening protocol, which has never actually been shown to reduce the incidence of myocarditis, but that's a weekly troponin IRT or weekly high sensitivity troponin and CRP until week 8. Myocarditis has been the subject of a lot of discussion. I think look at it's helpful to look at the Ronaldson protocol where this came from about when to actually stop clozapine. And it basically suggests when the CRP is 100 or when the troponin is twice the upper limit of normal. Sometimes people will have normal sort of CRP bumps during the course of a clozapine titration, and that's probably not a reason to stop it. We need better tests. We need more guidance. Myocarditis is an issue. I think the incidences vary between, 0.0, 0.5 to even up to 3 to 4%. Maybe a little high. Okay, so neutropenia. So we're going to talk about the hematologic monitoring. I'm sorry to delay that in the question, but I think it's helpful to kind of put it into the broader context. So for neutropenia, it is 1% of people will develop severe neutropenia. Not all neutropenia or severe neutropenia is life-threatening neutropenia. The risk of death due to clozapine as a result of neutropenia is 1 in 7,700. And then it peaks at a month. Most cases occur at a year. The risk decreases over 3 years. There's a lot of new data about sort of the hematologic risk and neutropenia and questions about are we even mostly, because everybody talks about the hematologic monitoring, but actually it's not the most common reason that people die due to clozapine. That's probably more due to ileus and slow gut and complications of that, more so than severe neutropenia. So the slow titration, which is so critical. If you look at the US package insert, like any normal person would, you would say, oh, okay, 450 milligrams after 2 weeks. That is way too fast. I think that is unsafe. Just personal anecdote. I wouldn't, I think there's been, some data on rapid titrations, but the slower you go, I think the better people will tolerate it. Like Anne was saying, less sedation. These are some guidance that we use. Rapid titration may be associated with myocarditis risk. And then also if people, have tolerability issues, they're going to be like, what are you doing? Let's stop this. This is, so slow titration can help with that. On the inpatient service, we might get to 400 milligrams over a month with pretty significant monitoring. And on the outpatient setting, maybe 200 milligrams over 4 weeks. So I've been a big proponent of the slow titration, and it's actually led me to some unexpected places. So I wrote this paper with a colleague called "The Tortoise Beats the Hare," because we're always trying to think about, ways people would get excited about the scientific literature. So we wrote this paper. It was an editorial. And the next thing I know, I got this invitation to write a paper in a veterinary science journal on reptiles. And that just was the height of my career. So, you never know what might happen. I'd never got invited to do anything on the rabbit science side, but maybe that's coming. Okay. Now, the point of care testing. So there's a commercially available product called Athelis One, and it's also available in Athelis Home. So clinics get Athelis One, the individuals themselves can get the Athelis Home device. It's FDA approved. It's CLIA waived. I think there's some issues with the home right now about if you can actually use that in the home. But the nice thing about it is that the results automatically upload to the REMS system. One of the big issues with clozapine is sometimes you need to actually fax the results of the labs to the pharmacy, which is another barrier burden, and that's difficult. But I think the Athelis device can be really, really helpful for ACT teams. Some ACT teams might have an Athelis device at, sort of at the home base, and then they may use them in the community. So they connect to your, I think they connect to Bluetooth on your phone, and it can be done in the field. I think the test strips cost about $30. The device itself, the price may vary depending on the time and the system and how many people are thinking about. But there's been a lot of work that's been done at the University of Maryland, and it really is talked about. People prefer the capillary stick drop of blood in comparison to venipuncture, and how this can really sort of improve access. All right, so I just want to throw out some advantages and disadvantages of this. I mean, the nice thing is it can really expand clozapine access. And I know a lot of people on ACT teams who, if they didn't have the Athelis device, there's just a certain percentage of the population they can't reach. On the other hand, I think for some things like myocarditis screening, interstitial nephritis, like if you don't have the venipuncture, you can't get those labs. So that's kind of one of the downsides. But I know some other colleagues probably have experience with the point of care testing. This is point of care ANC testing. This is not point of care levels. Does anybody want to talk about their experience with point of care? Because I actually don't have point of care where I am.
At University of Maryland, we've been using it for a while. Our Maryland Psychiatric Research Center facilitated access to the machines and did a lot of training with us. I am using it purely office-based, but I have a younger, way more tech-savvy colleague who plugs it into her car and sets up a hotspot and literally is, doing finger sticks in the field, which is just great from an ACT perspective.
I did have a question about then how do you go about getting one in your office? And I know this kind of lines up with the other question that was raised in a past call about whether you need certain agencies need certain credentialing or certification or something to be able to have something like that. Some of our past psychiatric care providers were told that they couldn't have one in their office or they couldn't be using it because of that.
Yeah, and I think, go ahead.
No, I believe that there is some kind of credentialing. I cannot remember the specifics, but I know that my colleague, has full approval for using it out in the community as well, and very specifically worked with the company that makes it to do all the things that she needed to do to get it set up to use in the field as well. In the office setting, we've needed Ethernet set up to be able to get the results forwarded appropriately. But it really can be a game changer in terms of people are so much less distressed by a single drop of blood. Granted, it needs to be a substantial drop as compared to a tube.
A related question was if there is insurance coverage for the at-home devices, and do those also upload to REMS, to the REMS?
So my understanding is the home devices do upload to the REMS so long as there is some degree of connectivity. Insurance coverage, I think, may vary, and insurance may cover the strips, but they may not cover the cost of the device. So systems may have to figure out how to cover that. I think the Athelis reps would probably be the best people to talk to about that. And yeah, I that's probably the way to think about it. So just the other thing that's sort of interesting that's newer is that there's this, the FDA is interested in this Codex Fire Accelerator community, which basically allows different types of data to pass across EMRs a little bit more seamlessly. And there's an idea that this data type may actually help facilitate clozapine use in the future. So it's possible that like if somebody gets labs at a lab core, it can go to a REMS information exchange where REMS will automatically be uploaded, and the pharmacy can get information to that. So the FHIR technology allows the data to pass through a little bit more easily. And there's some, test cases in progress now that FDA is looking at. So not ready for prime time yet, but maybe this will make it easier in the future. Okay, I'm going to talk maybe a little bit about, we have 20 minutes. Why don't I talk a little bit about levels, obtaining clozapine levels and interpreting clozapine levels. So, we'll talk a little bit about why you would want to get one, what are the different assays, why would you want to draw one, how do you interpret them, and a couple of key concepts. So like if you've never got one, it's okay. You're not the only person who's never got one. Most people actually don't get them. Only 47% of psychiatrists actually use levels to guide dosing, but maybe there's a change there coming. If you look at the ASCP and AGMP TDM task force, you can kind of see antipsychotics and which TDM is strongly recommended, has the highest level of evidence. Clozapine has the highest level of evidence, including fluphenazine, haloperidol, olanzapine, and perfenazine, and pyrazine not on there, but we don't have pyrazine. So why would you want to get a level of an antipsychotic? And part of the reason is, many people that are on antipsychotics sometimes don't take them. And I think you can actually, if you were to somehow improve medication adherence, that you could save a lot of money for the system. Also, not everybody responds the same to medication, and you got to figure out why that is. And sometimes therapeutic drug monitoring can help you. And I guess I would argue that a level is sometimes more valuable than like a panel of, like a genetic panel of CYP450 isoenzyme polymorphisms. The level actually tells you what is in front of you. You get the phenotype right in front of you. Levels can be valuable in almost every situation. Uncertain adherence, lack of response to established doses, high body weight, low body weight, certain ancestral heritage, going from one antipsychotic to another, and then sort of persistent symptoms. So there's a lot of, I think, evidence-based reasons to consider getting a level. Just as a reminder to everybody, clozapine is broken down into norclozapine by 5 enzymes in the CYP system. CYP1A2 does the majority of the heavy lifting, but also others are involved. The inducers, the common inducers are the aryl hydrocarbons and omeprazole, and the inhibitors for CYP1A2 are things like fluvoxamine and ciprofloxacin, which we talked about. Everybody on the ACT team needs to be aware that if somebody on clozapine gets ciprofloxacin, they need to sort of raise a concern. And people go into the emergency room and sometimes get a prescription like this. So it sometimes happens like outside of a system that people have knowledge of. And then these are the moderate to weak inhibitors of CYP1A2, including OCPs and caffeine, which is a substrate, not necessarily an inhibitor. But sometimes if you drink a lot of caffeinated beverages, that's a lot of CYP1A2 substrate and kind of functions like an inhibitor. Remember, though, that, for smoking and clozapine, this, it's not the nicotine, it's the aryl hydrocarbons that are produced when people smoke the leaf, and the burning process is what produces the aryl hydrocarbons, which actually, cause CYP1A2 to rev up. So, if you have a nicotine patch or you use the nicotine gum, it doesn't really do the same thing. You wouldn't expect any pharmacokinetic changes. Vaping also probably doesn't actually induce CYP1A2. Smoking cannabis, probably, if you smoke the plant, smoke a joint, that's probably going to induce CYP1A2, although the literature is fairly poor. Sort of orally ingesting cannabis products, not going to affect CYP1A2. Yeah, so clozapine levels are measured two ways. There's the LCMS MS, liquid chromatography tandem mass spec. And then there's also a new immunoassay that's been released that we use that's been really helpful and interesting. The the guidelines say that a reference range is 350 to 600, but if you have somebody at 600 nanograms per mil, persistent positive symptoms, the evidence would suggest that you can increase the clozapine dose and to get a higher level and perhaps get some increased efficacy out of the medication. At levels of greater than 1,000 nanograms per mil, there's a real risk of ADRs. So if you use clozapine levels, you have to know that there is a normal variation of clozapine levels, even if everybody's doing the same thing. And we call this the coefficient of variance. So you can expect a 30% coefficient of variance for clozapine. And just, I wanted to show you this graph here. You sort of get like an initial baseline level. And this person has a baseline level, let's say of, 350. And then you sort of like, I made, some boundaries that kind of bound in the 30% range. And you can kind of see like some of them are higher. And then this one really high over here in October. This one, I would say, is not a normal variant. And something else may be going on. But like sometimes families will say, oh, like clozapine level is a little bit different. What's going on? You can expect it to be a little bit different. For fluctuations greater than 50%, really think about non-adherence. Okay. There are, established norms on a concept called the concentration dose ratio for clozapine. You basically take the level and you divide it by the dose. And what's interesting about this is, it really speaks to the need for personalized dosing. Like, the goal is not to get everybody to 400 milligrams of clozapine because there is a massive variation based on even just male-female sex and smoking, non-smoking, the level that you would predict. So essentially, someone who's a male smoker is going to need twice the amount of clozapine as a female non-smoker. And at SMI Advisor, we have a tool called, it's like a clozapine pharmacokinetic tool that allows you to kind of use some sliders to, in real time, give you a prediction of what the level might look like based on the dose. So sometimes like when I'm starting clozapine with a new client, the question comes up, well, how much clozapine I'm going to be on? And I say, well, I don't know. Let's go down, let's take a look at the clozapine calculator here. And, we kind of input these variables. We would say, oh, well, maybe we want to know maybe a level of 350 might be like one idea. So then it gives us a predicted dose. Or you can also put in a dose and it gives you the predicted level. To be used with caution, but just gives you a rough ballpark. Okay, then there's a concept called the metabolic ratio, which basically allows you to take you look at clozapine and you divide it by its major metabolite, norclozapine, and that gives you the metabolic ratio. And it gives you some clues kinetically about what's occurring with the person. Like if the metabolic ratio is over 3, that means there's probably an inhibitor on board or a viral infection or bacterial infection. See this in the ER sometimes. If the MR ratio is less than 1, then it may mean that there's it may be the person smoking or maybe omeprazole, or there may be a CYP1A2 ultra-rapid metabolizer. So, we have our residents usually calculate the CD ratio and the MR ratio and try to make some sense of it. Let me just say this. So there's a new assay, the immunoassay, which I spoke about a little bit earlier, which is made by Salidex Biomedical, that allows you to get a clozapine level back on the same day. And this is important because it gives you much more real-time information. Normally, if you get a clozapine level, it comes back to you in like 5 to 7 business days. And so many times I've like got a level back. The level was drawn, 5 days ago. They call in the middle of the night. That's okay. But it's like, the level 5 days ago was 1350. And you got to kind of be like, okay, let me put my glasses on and let me call the person and kind of see how they're doing. And you just feel like, you really, you're talking about something that happened long ago, and they may be okay, and that you might have, they may not be okay. But the same day levels like really allow you to make much more real-time clinical decision making. I say this real quick about clozapine discontinuation and retitration, because this happens all the time. If you're sort of working with clozapine, there's been some updated package and insert information in 2023, which, it's not all that much guidance, but, if 1 day's dosing has been missed, resume treatment at 40 to 50%. If 2 days have been missed, resume dose at 25% of the established dosage. And, I think what happens is you're basically, balancing this risk between going too fast and going too slow. Like on the too slow side, if you don't get the clozapine titrated back quick enough, you can have significant symptom exacerbation. It's, cause suffering, medication withdrawal symptoms, but also too fast, it can be a problem. So this is a big challenge. And there's not a lot of guidance about it, but, this is sort of what we see a lot in our clozapine clinic. Is probably what a lot of ACT teams see is, people stopping clozapine abruptly. Maybe it's not even their fault. Maybe it's some issue at it's never anybody's fault, but maybe it's like the pharmacy, or they just couldn't get it and they don't have it. And, it happens on a Friday night and you got to figure out, what to do. I like to ask people a couple questions about like, how to retitrate. Because a lot of times people have actually done it on their own, and I'm curious about how they did it on their own and what was it like, and maybe it gives you a little bit of guidance about how to do it again. Also, like sometimes you can't let it's very difficult to lay out a very precise titration sometimes, and you have to do kind of what's more feasible for the individual. So maybe what we could do is stop there. We have like 8 minutes and is that right?
We do. We have 8 minutes. We have a couple of really good questions about side effects from clozapine. So that might be a good topic. Maybe we can just have you quickly go through those.
Yep.
Would that be okay? The first was just specific recommendations about how often you see urinary side effects, urinary retention, or overactive bladder, and how to treat that. And then there's a question about prophylactic anti-epileptic medication. So maybe speaking about the management of urinary retention.
Yep. Great question. And actually, like before I was a part of SMI Advisor, I actually wrote SMI Advisor with this very question in the consult service. It's really interesting. It's just like small world, but the first thing you got to do is you got to make sure there's no other anticholinergic medications on board. And then, you got to really, it's also helpful to sort of understand the cause of the urinary retention. Are there other causes? Are there additional medical workup that needs to be done? But it can be it's a problem because clozapine is highly anticholinergic. 50 milligrams of clozapine is like equal to 1 milligram of cogentin in non-smokers, and you see how much sort of anticholinergic that load that is. So sometimes the consideration could be dose reduction. That would be kind of where I would go first, but that's also a little bit of a tricky issue, especially if somebody's doing well. So, I think urinary retention is sort of a pretty tricky issue with clozapine. You got to ask about it. You got to ask about, not urinating enough, urinating too much. That's sort of another, sort of algorithm of things to go through.
No, it's helpful. And it's a good reminder to think about other medications as well. The other question was, is it recommended to use anti-epileptic medication at a clozapine dose of 600 milligrams and above prophylactically? And if so, which do you prefer?
Yeah, that's a great question. There is a good bit of debate about what people think around this. I think that the level is probably more important than the dose on this one. So, to me, the risk of seizures at like 0 to 1,000 milligrams is actually like clozapine has a risk of seizures, most commonly tonic-clonic seizures. To me, the risk doesn't really seem to using an AED at like levels greater than 600 doesn't really seem to be worth it. Once you get to a level over 1,000, I think that's maybe when I would start to consider using an AED. The problem with AEDs is they have their own issues. And the best option is often sodium valproate because that will treat tonic-clonic seizures, that'll treat it will sort of treat the positive and negative myoclonus that you see with clozapine. I think that you see, sort of increased risk for other problems when you kind of use clozapine and valproate together. Like if there was both like a cardiometabolic standpoint, like you would expect potentially weight gain, you may expect increased risks of thrombocytopenia, neutropenia with sodium valproate. So I really don't like to use it prophylactically. There are some people who it may make more sense for, maybe for people who have had a history of seizures, who have had a traumatic brain injury, so I think you kind of have to take it case by case, but I don't usually routinely use AEDs for levels over 600 reflexively.
Okay, that's helpful. But then you do think about Depakote if you were to use one
Yes.
over 1,000. Okay, that's helpful. Well, I know we just have a few more minutes. One other question, kind of big issue related to weight gain and metabolic risk. It's a nice segue because we have Martha Ward, your colleague from Emory, coming to talk next month about, not specific to clozapine, but about metabolic issues with antipsychotic medications. But there was a question just, I think, sort of asking about your general approach, that it is, it's a concern for many patients, and maybe how you discuss this with patients and families as you're proposing clozapine. I don't know if you have a quick, kind of a quick statement about that, how you frame it, kind of maybe risk benefit.
Yeah, I mean, I think I usually talk about it like, weight gain is a very, very common side effect of clozapine. The way that weight gain most likely occurs is through hypothalamic dysregulation and increased appetite and sort of hyperphagia, which really causes it. It probably doesn't have to do with sort of affecting the basal metabolic rate or sort of other issues, but weight gain is very common, and I like to routinely start metformin with everyone on clozapine, and there is some data that suggests that this is from Mahavir Agarwal and his group in CAMH in Toronto, suggesting people who were started on metformin actually stay on clozapine longer, so there was a benefit in the adherence side as well. I like to try to get the metformin to 2,000 milligrams if I can. Metformin has its own side effects. Slow titration is very important, but metformin right out of the gates, pretty much for everybody. Not everybody is open to it, like people are already on a lot of other medications, and like it's totally understandable, but sort of offer it routinely in the process of using clozapine. After metformin, because for some people, clearly metformin doesn't do it. I've had some people who are excellent metformin responders for which, no other intervention is necessary. I think at higher doses, it typically does better. Sometimes long-acting metformin can help to reduce some of the GI issues. But then I think now the big question is using GLP-1 receptor agonists and the dual GLP-GIP agonist tirzepatide. So, many people on clozapine will have type 2 diabetes. Just many people with serious mental illness will have type 2 diabetes as as another comorbidity, or obesity or overweight. So now I think there's many more opportunities to use GLP-1 agonists on label and have a better chance of getting them covered. the best data for GLP-1 agonists. There's many studies that are in progress now, but liraglutide has been the one that's been studied that, has basically shown that clozapine or olanzapine treated patients who are on liraglutide tend to, fare better from a cardiometabolic standpoint. But nowadays, many people are using semaglutide and tirzepatide to help sort of offset this. They do really well. The problem is that they slow down the gut. So we often use sort of, we will use polyethylene glycol and other sort of medications to help people stay, kind of keep going, because there's a risk of gastroparesis and ileus with GLP-1 receptor agonists. So sorry, there's no way to put that in a short response. I apologize. Could go on and on. Could drone on and on about this one.
Yeah, me
Great
too.
question.
And we'll have an opportunity to talk next month. I see that Peyton has put the QR code for the evaluation and a link to the evaluation in the chat. I think just, kind of thinking about GLP-1, approval for just wondering if you have any final tips about approval, insurance approval, if it's not for diabetes. Have you had any success with that? Is the other part of the question.
Highly varies.
Yeah.
Based on the insurance company.
Yeah.
And also, I think it's important to document, sort of failure of other interventions for weight, like including metformin and sometimes topiramate. And then sort of, you also need for the insurance company sometimes documentation of failure of diet and lifestyle interventions, which it's hard to just sort of start out with that. I think you often can successfully get to GLP-1s after, trying a lot of things and really documenting carefully and
Building your case.
Documenting the weights, which is sometimes difficult when there's like virtual visits and things.
Great. Hey, well, thank you so much. We just want to thank you for a wonderful presentation and a great audience, great questions from the audience. So reminder also in the chat about next month's session, the third part of our 4-part series. So thanks again, Dr. Cotes. It was a great presentation.
Thanks, everybody.
Thank you. Thanks for joining. Bye-bye.